Hello, this is Julie Rice, and I'm going to be talking about a subject near and dear to my heart, which is educational program adaptation. It's more exciting than it sounds, I promise. Specifically, I want to talk about the fact that I think it's time to more consider national culture when designing patient safety curricula, especially those curricula that are being designed and exported. And I'll get into what I mean by that in a moment. But first, I am the director of simulation education in the Johns Hopkins Emergency Department, and I'm also a clinician there. I have a master's in medical and healthcare simulation education from Drexel University, and I am a patient safety advocate, have a lot of different international teaching experience, which I enjoy. And up until the era of COVID, I was grant supported in Lebanon at the American University of Beirut Medical Center to implement patient safety programming and specifically team steps training there. My co-conspirator, Dr. Isha Chopra, is my assistant simulation director in the Johns Hopkins Emergency Department. She's also a clinician there and at Bayview Hospital in Baltimore. She's an advocate for psychological safety and healthcare training, and also has a lot of international teaching experience and has assisted me in the patient safety programming that I have performed in Lebanon. So I want to go into a little bit of background. For those of you not familiar with the safety culture movement, in 1999, the Institute of Medicine issued a report called To Err is Human. This famous report estimated that up to 98,000 hospital deaths a year were being caused by preventable errors. And when data was broken down, root cause analysis, malpractice claims data, many people found it concerning that it was breakdowns in communication and teamwork that were often cited as the root cause of this preventable medical error. So patient safety really became a focus, and specifically communication training, team training became a focus of lots of safety initiatives. So this really was taken as a cue from the aviation industry, and I'll be speaking a little bit more about why the aviation industry was looked to as a team training safety expert. But they looked at aviation industry, and many different programs were developed to address these knowledge gaps in team training. Many programs were developed, and most of them were developed in a Western context. Almost all of them were actually developed in the United States. You can see the list of some of these programs here. Why were they developed in the United States? Well, it turns out that in 2001, a few years after that To Err is Human report, the US Congress authorized the National Defense Authorization Act, which mandated and funded the implementation of safety-focused team training in US military treatment facilities. So the Department of Defense was funded and mandated to get involved, and they partnered with the Agency for Healthcare Research and Quality to determine what the problem is, what gaps needed to be filled, and what training should look like. And the result of all of their work was the Team Steps training program. So I do speak a lot about Team Steps because of its wide implementation, but a lot of these other programs were developed around the same period of time because of the, as I said, funding available and the mandate that we needed to have better team training. Most of these programs are very similar. They use a systematic methodology to improve communication, collaboration, and coordination among teams. They give people different tools on how to talk to each other, how to challenge authority respectfully and be heard when there are safety concerns. Almost all of them provide teaching content such as PowerPoint slides, handouts, or educational course plans. Many of them have opportunities for practice and feedback, either tabletop games or simulated practice with instructor feedback. And almost all of them provide tools to help operationalize the skills that are learned in training into the clinical setting. So they're very common, but the reason why I talk about Team Steps the most is because it has been one of the most widely implemented. By 2017, the Agency for Healthcare Research and Quality estimated that up to 35% of healthcare workers in the US had had some form of training. And this has been translated in over 20 languages, and a quick PubMed team steps search can demonstrate to you that this has really gone around the world, and it has been widely implemented. Many people believe it's because the AHRQ allowed all of their materials to be used for free and had those easy to access on their website. So these educational materials were very easy to access, and part of that was their desire to really get this training out there. So they did a good job of that. And this slide is taken from Team Steps, but many of these training programs have a similar assessment phase. You can see here in phase 1, there's a pre-training assessment that includes a culture survey, a site assessment. People collect data through different safety culture surveys to really decide what are the issues that need to be addressed with training. Now, you see culture survey there. What that refers to is local organizational culture. This is also informed by professional culture, meaning the culture of physicians and the professional culture of nurses. But the cultural assessment surveys really look at the organizational culture of the hospital and not necessarily national culture. So when I was taking this training to a different country, into a different context, Lebanon is not where this was created. It was created in the United States. I thought to myself, is it important for me to consider national culture when I was kind of designing or adapting patient safety team training programs? So when I was answering that question, I first backtracked a bit, and I decided to look at what aviation has done in the past. Now, aviation is where a lot of this team training, where a lot of the team training concepts came from. Aviation, unfortunately, in the 1970s, there were many more accidents than there are today. And in 1977, at Tenerife Airport, the deadliest accident in aviation history occurred, where 2 jetliners full of passengers crashed into each other. This event shocked the world and motivated the FAA, to look at what happened there, how can they prevent it, and they did find that it was issues with communication and hierarchy within the cockpit of one of the airlines that really led to this crash. So after that, they decided to to develop what was called at the time cockpit resource management, which trained communication and hierarchy flattening techniques within the cockpit. And later it expanded to crew resource management, which not only looked at the interactions between those in the cockpit, but also expanded it to the interactions of everyone that operates the plane, including or is involved in the operation of the plane, including ground crew and flight attendants. So they developed this, and what was the outcome? Well, the outcome was, in the United States, they started seeing a decrease in safety incidents. They started seeing a decrease in planes crashing, and that quickly prompted the International Civil Aviation Organization to require that all carriers implement similar programs. So they have this great crew resource management program. It's going to go around the world, and that's great, right? Well, they start running into problems almost immediately. There's actually entire books written about this. One of them here by Heimrich and Merritt, who are considered aviation safety culture experts, actually look at exactly this problem, how culture impacts training. And the reason why there are whole books written by aviation experts on how culture impacts safety training is because of these problems they saw internationally. When the US crisis resource management training, when they tried to bring it to, for example, Japan, you have a training that was really focused on independent, individual-oriented pilots, and now you're trying to translate it into a cultural context where group orientation, group cohesion, modesty have a much higher value than in the United States. And when these were not acknowledged, things like speaking up behaviors, assertion behaviors that are taught in safety culture training, they were not translating as well. So when they saw this problem, experts such as Helmrich decided to look at national culture and maybe what the impact was. And they started with a very large survey, 15,000 pilots from 23 countries. Their analysis showed that their analysis was based on a national culture model by Hofstede called the Cultural Dimensions Model. And they compared different countries' pilot responses to their different cultural dimensions profile and found that there are 6 clusters of countries that have similar responses and work values. Well, this means that when you adapt your curriculum to use in another context, that now it may be able to be translated better into those in the same cluster. So this clustering came from their work very early in the 1980s, especially when you compare it to where we are in healthcare today. They found that national culture differences most impacted areas of command, endorsement of rules, and attitudes towards automation, which of course in aviation is very important. And now safety experts are expected to account for national culture in their program planning. They're expected to perform a cultural assessment. They're expected to engage boots on the ground and get more impact in how these safety culture tools and behaviors that you're trying to promote translate into that culture. So they looked to models of national culture in aviation. So I thought, well, what about these models? Is there one model? Is there more than one model? There's actually many models of national culture. Many different sociologists and psychologists have approached this issue of how to kind of create a map of of those that are part of a certain national culture. Now, it's important to say that this does not define any individual within that culture. It's more tendencies based on that national culture. Most of these models sort into 2 groups, either shared values like the Hofstede model or shared norms like Gelfand. So Hofstede has these cultural dimensions, which many people are fairly familiar with. But it's easy to see immediately how differences in these cultural dimensions, and this is how Hofstede has defined cultures are different than each other on a national cultures. It's easy to see how they might affect safety culture. For example, we'll just take the first on the list, power index. This is the extent to which less powerful accept that power is distributed unequally. And this is based on the subordinate perception. So if you have a high power index, that means that there's more tolerance of hierarchy and subordinates may be more hesitant to raise concerns. Well, I would want to know if I was teaching in a high power index or a low power index context as an educator, because I need to know if I need to emphasize more and normalize more speaking up behaviors, which are so important in safety culture training. So that's just an example from Hofstede's. Gelfand, on the shared norms spectrum of national culture models, speaks about tight and loose cultures, where tight cultures have strong social norms and are less tolerant of individual behavior deviation, and loose cultures better tolerate individual behavior deviation. So again, it would be helpful for me to know, is this a tight culture where new behaviors may be seen as deviations and may be stomped out by the other units that like haven't had training? Or is this a loose culture where new behaviors or new behaviors or individual behaviors may be more tolerated and not seen as something that's negative? So in the interest of time here, I could talk about why this is important all day. I could talk about other culture models, but I think it's most important to get to some recommendations for how we should account for national culture when we are taking training programs from one national context and then applying them in a different national context. So I want to go over how we can account for that best at this time. So first of all, be proactive. You need to start by acknowledging that there are differences in national culture, along with organizational culture and professional culture that that may exist, and to just bring that up at the outset. Emphasize that no culture is right or wrong. The way that I found was helpful was to frame new behaviors as tools and not correct behavior. When a behavior such as speaking up behavior went against the norms for the national culture context in Lebanon, it was very important for us to brand it not as this is new, better, or correct behavior, but that this was a tool that in the healthcare context is a safety-oriented tool. And that slight frame shift really helped people adopt these tools and also gave them the language to teach these tools to other people. Also, I cannot emphasize enough as an educator, a needs assessment, but here I think it's important to perform a data-driven cultural assessment. This is best when it includes quantitative and qualitative data. The quantitative data really helps you look at your impact over time, but the qualitative data, such as from interviews or group focus groups, this can really help you determine whether or not you have cultural congruency and what we call if the context is similar. So you need to make sure that the concepts will translate. So when I'm speaking about certain concepts in my, I'm from the United States, when I'm speaking of certain concepts to somebody in a different cultural context, does that translate? So do they manifest, does safety culture concept manifest in the target culture the same as it does in my culture? How do we make these contexts more equivalent between the cultures? So that interview data can really help you with that. You should look for pre-published regional data. When I was working in Lebanon, I looked for safety culture data that had been published in the Mid-East area region. And then I tried to compare, because the national cultures are very different in that region, what countries are more similar to Lebanon and what countries would be different, and how can I use the more similar countries' regional data, because I did not have data from the Lebanese context. So like I said, you need to determine construct equivalence on issues related to safety culture. For my group, we really did this through interviews and really getting people to define what things meant to them so that I could inform our curriculum, what these concepts meant to them. Also, looking to those models of national culture, such as to look for shared norms or values, that can help determine how training may transfer and what elements of training that were developed in one context may transfer easily to another context, or what may have difficulty when there are, for example, large differences in that power index or large differences in uncertainty avoidance. And then lastly, I cannot emphasize enough the importance of curriculum piloting. We piloted our curriculum in Lebanon and actually utilized a train the trainer model. I, as an outside consultant, came in and taught this group of like highly engaged physicians and nurses and support staff on the Team Steps model. That was considered our pilot curriculum, and going forward, our widely disseminated curriculum was greatly informed by feedback and discussions we had during the pilot curriculum. During that pilot curriculum, though, we were really training the trainers, and they had a lot of extra training after that. But what the trainer model allowed us to do was have another layer where this is translated into a local context. And you can see here, we have a training going on in Lebanon taught by a local trainer. And this allows them to, again, make sure that we have that construct equivalence. And I was really there more as a facilitator in the early wide dissemination phase to answer questions and to provide clarification and further refine the curriculum. But it was really those local trainers who did such a great job and took it on and made sure that things translated. So, and also please publish your data when you get it. It looks like I'm out of time, so I am always appreciative of questions, concerns, collaboration ideas. Please email me, and I have a complete list of references, a few of which are here. Email me if you're interested in the complete list. Thank you so much for your time.